A warm welcome to everyone to the anesthesia class. The topic that we are going to discuss today is oxygen therapy devices. See, when it comes to oxygen therapy devices, two kinds of questions can come. First, image based, where an image will be given and concerning question would be asked. And second could be a case scenario in which the most relevant oxygen therapy device which can be used can be asked. So let's move forwards with oxygen therapy device. See, what does oxygen therapy means? As the name suggests, it means providing oxygen above the room air concentration. That is oxygen therapy. And when we differentiate between hypoxia and hypoxemia, it is hypoxia is the deficiency of oxygen at the tissue level, whereas hypoxemia is your arterial pressure of oxygen is reduced. When we talk about the hypoxemia, before we study about the delivery devices, we have to know the severity of hypoxemia because the choice of oxygen delivery device actually depend upon the degree of the hypoxemia that the patient is suffering from. For example, the normal levels of PaO2 in our body are 80 to 100 millimeters of mercury, mild is 60 to 80, moderate 40 to 80, and severe is less than 40 millimeters of mercury, means severe hypoxemia. In normal, the patient is normal. Then in mild and moderate, generally we use our oxygen delivery devices which are non-invasive or they're not definitive. But when we have severe hypoxemia, then we go for endotracheal intubation or mechanical ventilation for the patient. Talking about the indications of the oxygen therapy, these are must to know indications. All these indications you have to know. Most of them are common sense indications like cardiopulmonary resuscitation. Of course, you have to provide oxygen to the patient. The fall in PaO2 to less than 60 millimeters of mercury or the fall in saturation. The patient is suffering from shock of any kinds. It may be a cardiogenic shock, a septic shock, a hypovolemic shock, or the shocks. The first step of resuscitation is provision of oxygen. Then metabolic acidosis. Metabolic acidosis actually takes place when there is anaerobic metabolism going on in the body. For that, of course, you need oxygen therapy. And lastly, any type of respiratory failure, 1, 2, 3, 4, will be needing oxygen therapy as a first line of treatment. Now, these devices can be classified. See, this classification is how you are going to describe a device. For example, we take a device like nasal cannula. So, nasal cannula has to be described under these headings. So, first coming to the classification part and understanding what the classification is. The first, low flow and high flow. As the name suggests, low flow devices would be those devices which will be giving the fresh gas flow at a rate of around 5 liters to 8 liter per minute. Whereas when we talk about the high flow, they can give around 15 liters per minute to even 60 to 70 liters of oxygen or fresh gas flow per minute. Okay, please understand, I'm not talking about only oxygen. I'm talking about fresh gas flow, which can include oxygen plus entrained air also. Okay, let me be very clear. When I'm talking about low flow and high flow gas, it means oxygen plus entrained air also, and not only oxygen. Okay, means it depends upon device to device. Second is fixed and variable performance device. As the name suggests, the fixed performance device means the fraction of inspired oxygen will be fixed, whereas in variable, it will vary. Okay. Patient dependent, patient independent. Now a device which is giving us a fixed FiO2. That device is independent of the patient's characteristics, right? Because the device has been made in such a way that it has to deliver a particular FiO2 to the patient irrespective of what are the patient's characteristics. That is patient independent device. And the second device, which is variable performance device, the FiO2 is variable and that will vary according to the patient's requirements. Then we have degree of dependency, how much the patient is dependent on that oxygen therapy for maintaining the oxygen levels in the blood. Low dependency. By low dependency, we mean that the patient needs only supplemental oxygen, right? Medium dependency. Along with supplementation of the oxygen, the patient also requires some respiratory assistance. Okay. And high dependency means the patient cannot it cannot maintain an oxygen level on its own, or rather the patient is not able to maintain his respiration on his own and needs almost a complete support of respiration. That is high dependency. Then last we come to capacity of a device. By capacity of a device, I mean how much oxygen reservoir the device has. By capacity, we mean oxygen reservoir. Like in some devices, we don't have any oxygen reservoir. In some, we have low volume oxygen reservoir like 100 ml. Then we have medium, 100 to 250 ml of reservoir of oxygen is maintained. And in high, we can have around 1000 to 1500 ml also. And very high is above 1500 ml. We have volume present in the device which can be filled with pure oxygen. That is your capacity. I repeat, by capacity we mean the reservoir of oxygen. So this is how you are going to classify all the devices. Coming over to the differences. First is fixed performance and variable performance. These are the concepts that you have to understand because various MCQs in one or the other way comes from these differences of the fixed performance and variable performance. By fixed, I've already told you they have a fixed FiO2. Maybe a range of FiO2 is present, but if you're talking about a particular device, that device is going to give an FiO2 of that much amount. Done. Variable, it will vary. Characteristics are rebreathing. In fixed performance, there is a very high flow of your gases. The fresh gas flows that you give are very high. That is the main reason why it is independent of the patient's characteristics. Please understand one thing. We have a peak inspiratory flow rate, or you can say mean inspiratory flow rate. During our respiratory cycle, we have a peak inspiratory flow rate. And any device which gives a flow rate which is more than the peak inspiratory flow rate of a patient will be able to provide with the fixed FiO2. Okay, because if such high flow rates are coming, which is maintaining the peak inspiratory flow rate of a patient, then the patient need not get extra air from the atmosphere to meet up the demands of the inspiratory flow rate. I hope I'm very clear. What is it is, I'll again explain. All the devices' performance depend upon two things. One, what are the patient's characteristics, right? Suppose the patient's peak inspiratory flow rate is say 20 liters per minute, okay? And one device is able to provide the fresh gas flows of around 30 liters per minute. So the patient's requirement is being fulfilled by that device itself, and the patient need not take or entrain air from outside in order to maintain its peak inspiratory flow rate. And thus, the device is able to provide a fixed FiO2 of its own, which is just the vice versa in variable performance. They are low flow gases and thus they are not able to maintain they're not able to make up till the peak inspiratory flow rate of the patient, because of which in order to maintain that flow rate of its own, the patient has to entrain air from outside, and thus the FiO2 which the device is providing will get diluted because of that entrainment of the air, and thus we'll have a variable FiO2. You'll never be able to guess, or you can only give a range of FiO2 that yes, maybe the device is delivering 20%, maybe the device is delivering 50%, depending upon the requirements of the patient and how much fresh gas flow have you opened. Okay, that is your variable performance. When we talk about rebreathing part, in fixed performance, I told you there is very high flow of gases that are coming. If a very high flow of gases they are coming, it is able to redistribute all the exhaled CO2 into the atmosphere. So there is no rebreathing of CO2 seen in fixed performance high flow devices. Whereas in variable flow devices, because there is low flow and thus some exhaled CO2 mixes with the fresh gas, and thus we have a rebreathing that occurs in variable performance devices. Done. Indications. In indications, we use fixed performance to give us controlled oxygen therapy. Okay, we give us controlled oxygen therapy, which could be like your Venturi mask or even your mechanical ventilators per se. They give a fixed performance because their FiO2 is set and it is independent of the patient's characteristics, and a particular amount of FiO2 is going to be delivered to the patient irrespective of patient's characteristics. Whereas in variable performance, they are used in those cases which have mild to moderate hypoxemia and controlled oxygen therapy is not required. So variable performance, maybe the patient is getting 30%, maybe the patient is getting 40%, but it is less relevant in these cases. I hope I have made myself very clear about the fixed performance high flow devices and variable performance low flow devices. We have already discussed about the dependency, low dependency, medium dependency, high dependency. In low dependency, we have spontaneous breathing that is present. We have your nasal prongs or your face mask. In medium dependency, we have spontaneous ventilation that is present, but some amount of respiratory assistance in the form of CPAP is also required. Talking about high dependency, we don't have spontaneous breathing or it is highly unreliable, and thus maybe you need non-invasive ventilation or maybe endotracheal intubation is needed for such a patient. Now this involves the use of ICUs, OTs or maybe your non-invasive ventilators. I hope the classification of the oxygen therapy devices is clear. Talking about one more very important factor, one very important part is that how the fraction of inspired oxygen that goes to the patient is controlled. Now, it can be controlled via two factors. One are your equipment factors and the other is the patient factor. The equipment factors is how much flow rate of oxygen you have opened first. Second, if you're talking about any device per se, every device, every equipment has a dead space in it. By dead space, I mean that there is some part, like we had talked about the circuits. In the circuits, we have some part where the gases are flowing, but there is no exchange that is taking place. So that is the dead space of the equipment. Then the volume of the reservoir bag. The reservoir bag volume will decide how much FiO2 that the patient will be getting. How fit the mask is to the patient so that lesser is the leak, better would be the FiO2 being delivered to the patient because less dilution from the nearby air will be there. And lastly, we have vents. We'll be coming to this that in various oxygen therapy devices, we have certain vents which are present for the exhalation of the CO2. But the same vents can also lead to dilution of the fresh gas by addition of the or entrainment of the air if the flow rates of your oxygen therapy device do not meet the peak inspiratory flow rate of the patient. Then we have patient characteristics. The FiO2 will highly depend upon the respiratory rate, the tidal volume, the pattern of respiration, the peak inspiratory flow rate, and obviously the anatomical reservoir, that is the dead space. If you all remember, we all have a dead space which starts from the nose and the mouth till your terminal bronchioles. That is the dead space. Okay, by dead space we mean there is conduction but no exchange. It is just a conducting zone and no exchange of the gases takes place. So that is a dead space starting from your nose and nares till your terminal bronchioles. Okay. When we talk about the dead space, it is like in infants, we have 3.3 ml per kg of anatomical dead space. In adults, it decreases to 2 ml per kg. You all have to remember these values. In adults, the dead space is 2 ml per kg, whereas in children, less than 6 years of age, the dead space is 3.3 ml per kg, and above 6 years, it becomes almost like 2 ml per kg. When we talk about the age, in geriatric patients, every year at least 1 ml of dead space increases. I repeat, in children it is 3.3 ml per kg, less than 6 years, and more than that it is 2 ml per kg. But in geriatric age group, it increases by 1 ml per year. Done? Then you have additional factors that can affect the FiO2 like the use of nebulizers or humidifiers. Now description. One by one, I'll be coming to the oxygen therapy devices, and these are the headings under which we'll be studying those devices. First of all, I'll tell you about the FiO2 that the device will be able to deliver. Then what kind of device it is. It is low flow or high flow. What kind of dependency it has. Then what is the performance of the device and at what flow rate the device is going to work and whether the device has a capacity or not. Then we'll discuss in brief the uses, the advantages, disadvantages of the device, and eventually we come over to the sterilization. The very first device is your nasal prongs or nasal cannula. How to describe this or how to identify it? It has these two soft silicone tubes which will enter your anterior nares. Please remember, they enter your anterior nare and not your posterior part of they don't go to the posterior part of your nose. They are only held at the anterior nare and they're hardly 1 millimeter or around 2 millimeter in size. Then we have this head strap and this adjusting head strap in order so that they are in the correct position. This is what is attached to the flow meter and this hole is your tubing. Now flows. It's a low flow, variable performance, and as you see there is no reservoir, no capacity device. Okay, and the FiO2 which gets delivered, the maximum FiO2 is 44%. Done. The flow rate that the nasal cannula gives is 4 to 6 liters per minute. What happens in a nasal cannula is that for every 1 liter per minute, it delivers a FiO2 of 24%. And for every 1 liter increase, you can see the FiO2 to increase by 4%. By every 1 liter increase, the FiO2 increases by 4%. So if it is 1 liter, the FiO2 is around 24%. If it is 2 liter, the FiO2 would be around increase by 4%, 28%. Similarly, if you have 3 liters, then again 4% have to be added, then 32% and so on. And eventually the maximum FiO2 that it can deliver is 44% and it has no capacity and no reservoir. It is made up of silicon or PVC and the anatomic reservoir, their nasal prongs has an anatomic reservoir which is your nasopharynx. As such, the equipment does not have a reservoir. I hope nasal prongs are a bit clear. Then the uses of the nasal prongs would be generally they are used in the recovery phase or you can use it in post-operative rooms also. They are used in patients who maintain a saturation above 95% and they're not tachypneic also. Now, they are very comfortable to be used because at very low flow rates they can be used very conveniently by the patient. As the patient is comfortable, there is no claustrophobia, the patient can talk, the patient can eat, so the compliance for nasal prongs is really good. But when we talk about the disadvantages of it, first we have a limited FiO2 that can be delivered. Then there could be latex allergy or allergy to the material that the nasal prongs is made up of. Then the obstruction could be there because of the nasal prongs. There is a little difficulty in maintaining the nasal prongs. Most importantly, in infants, whenever you are using the nasal prongs, the flow rate has to be less than 2 liters per minute, because if even 2 liters per minute of the oxygen therapy is given via nasal prongs to an infant, it will give an inadvertent, which is not needed, CPAP to the infant. So when we talk about infant, the flow rates of the nasal prongs decreases to 2 ml per kg, and the FiO2 is variable. I hope I'm very clear about the nasal cannula. When we are talking about the FiO2 which is being delivered, it depends upon the flow rate of the oxygen that you're given, the minute ventilation of the patient, and also the peak inspiratory flow rate of the patient. It is just a revision which I'm doing. I just told everything about it. Coming to the next device, nasopharyngeal catheter. As the name suggests, again, it's a nasopharyngeal catheter whose size is decided by keeping the catheter from your LA nasi till the tragus of your ear. And this portion is then marked, and you insert this catheter via your nose using a lubricant jelly till the tip of the uvula. Just remember this, that the ideal position for the nasopharyngeal catheter is nothing but just at the tip of the uvula, and not, you don't have to touch the uvula, or you can generate a gag reflex. As you can see, there is no capacity for it. It is low flow. It is variable. Various sizes are present of the nasopharyngeal catheter, like 8 to 14 gauge size it's present, and it is quite similar looking like your suction machine. Even nasopharyngeal catheter has an anatomic reservoir, which is your oropharynx. If I repeat it again, the nasal prongs has an anatomic reservoir, which is the nasopharynx, whereas the nasopharyngeal catheter also has an anatomic reservoir, which is your oropharynx. Oropharynx. The side effects remain the same like nasal cannula. This has to be changed daily, and you can alternate it between the noses, like first you have left, then you have right, every 8 to 12 hours. Okay. Catheter has to be changed daily, and alternate between right and the left has to be done every 8 to 12 hours. It has sorry, it has no capacity. Now talking about the nasal mask. See, this is the nasal mask. You have to differentiate the nasal mask from the CPAP mask. The CPAP mask is, it covers both your nose and mouth, whereas nasal mask is specifically meant to cover only your nose. This is the nasal mask. This is the connector which will be connected to the breathing circuit. These are the head harness or the head straps. The FiO2 which is delivered by nasal mask is around 60%. The disadvantage are that the mouth is open, so there will be dilution. And the advantages of nasal mask are, it delivers a higher FiO2 as compared to nasal catheters and nasal prongs. Plus, patient can speak, less claustrophobic, you can talk to the patient. So these are the advantages of nasal mask. The disadvantages could be, first, the gag reflex, because I know that some of the catheters can go and touch the uvula and generate a gag reflex. Then trauma can occur, obstruction can occur, there could be excessive secretions that are coming, skin can be irritated, then obviously gastric distension could be one of the complications, because air is sucking in, the air is going in, it is sucking in continuously. Then one important thing that can come as a Case-based question is frontal sinus pain. What generates the frontal sinus pain? This is generated because of the excessive flows that are generally given in your nasal catheter or nasal prongs that can lead to pain in the frontal sinuses. Okay, excessive flow rate from your nasal cannula, nasopharyngeal cannula, etc. That can lead to frontal sinus pain. Coming to very important and very commonly used mask, which is your Hudson mask. This is the most common mask, that is your Hudson mask. The capacity of the, when we tell low flow, variable. Okay, it's low flow, it is variable. FiO2 it delivers is around 40 to 50%, and by capacity, yes, it has capacity which in adult Hudson mask is around 70 to 100 ml, whereas in adult Hudson mask it is around 100 to 250 ml. That when we talk about the Hudson mask, one thing we have to be clear about the flow rates. The flow rates in the Hudson mask have to be at least 5 liters per minute. Why? Because lesser flow rate than it can lead to CO2 rebreathing. I repeat, if we give a flow rate of less than 2 ml per minute via a Hudson mask, this reservoir becomes, this part of the mask becomes a reservoir for the exhaled CO2, and thus we can have more of rebreathing. So a minimum 5 liter per minute of flow of gases is required via the Hudson mask in order to prevent CO2 rebreathing. I hope I'm very clear about the Hudson mask. Hudson mask has this part of the mask, then the tubing. These are the strap or harness or strap for stability. And sometimes we have a metal ring also like this, which pinches the mask on the mouth. This is your Hudson mask. It has a capacity, I've already told you, it's low flow variable. Coming to nebulizer face mask. Please visit the OT or ICU once and have a look at the nebulizer face mask. The only special part of the special thing about this mask is the presence of this chamber. The presence of this medicine chamber in which you put the medicine, then you join this nebulizing mask with the nebulizer, and because of that frequency that is coming, the water or the medicine that is present in the medicine cap that changes into a mist form and it is inhaled by the patient. That is a nebulizer face mask. That the good thing about it is that the oxygen that is coming via this, it is humidified. Done. It is low flow again, variable performance, and some say that it is medium capacity. It is a medium capacity device. The FiO2 it gives us 50%, and the one major disadvantage of using nebulizer is the sound of the nebulizer. Coming over to the non-rebreathing mask. See, we have two types of mask. One is partial rebreathing mask and other is non-rebreathing mask. Both of them are low flow, high capacity devices because both of them have a reservoir bag attached to them. But it has variable performance and FiO2 can change. Done. The maximum FiO2 which can be delivered via, first let's understand the difference between non-rebreathing mask and partial rebreathing mask. As you can see this mask, there's a valve present here. This is a one-way valve which is present at the exhalation port. Please remember one thing, that this very valve which is present over the exhalation port has to be present outside the mask. This valve can never come inside the mask. Okay, it's always present outside the mask. When it is present outside the mask, so when we exhale, then by pressure this opens and all the gases can be vented out. But when there is inhalational, then entrainment of the gas is stopped because that valve is one way. It was outside. When the outside pressure increases, it will collapse over the hole and thus there will be no rebreathing that can occur. This is non-rebreathing mask. What happens in partial rebreathing mask is One more thing, other than these two walls, there is one side wall which is present between the mask and the reservoir bag. Okay, this is also one-way valve that it allows the oxygen to flow from the bag to the patient, but it does not allow vice versa. That is, from the patient to the bag, it cannot happen because of the presence of that single or one-sided valve. I'm sure I'm very clear about the non-rebreathing mask. What happens in partial rebreathing mask is there is no valve. The valve is absent, because of which we have rebreathing that occurs, but that rebreathing will depend upon what fresh gas flow rate has been set. Now, what is the use of partial rebreathing? Can you think of even a single use of partial rebreathing? See, the use of partial rebreathing comes, for example, when you have preserved the oxygen. When you have to preserve the oxygen but maintain the flow rate, so let some amount of exhaled gases get mixed up with the inspired gas, and thus lesser amount of flow rate of oxygen will be required in comparison to the mixture of the gases which are providing a FiO2. So thus, when you have to conserve your oxygen, then you can use your partial rebreathing mask. I hope I'm clear. The FiO2 which can the rebreathing, non-rebreathing mask deliver is around 80% of FiO2. This is around 80% of the FiO2. See, this is the oxygen port. This is the oxygen port which is attached to the flow meter. When the flow meter is switched on or turned on, the oxygen is going to flow into the reservoir bag. The reservoir bag has to be kept around half to one-third fill always. Always this reservoir bag has to be maintained. And for maintaining that, we have to provide at least 10 to 15 liters of liter per minute of flow is needed from the oxygen flow meter, so that in order that at least half to one-third of the reservoir bag is always filled, we give around 10 to 15 liters per minute of FiO2, or the flow rate is around 10 to 15 liter per minute. The FiO2 it delivers is around 80%, and there's no rebreathing in the non-rebreathing mask. Done. It is a high capacity reservoir bag, a low volume, and a low flow and variable performance device. The FiO2 is not fixed, and it is dependent upon the leaks that are coming from the face mask. The minimum flow which is required for this face mask, I've already told you just 2 seconds before, is 10 liters per minute, because that much amount of air or oxygen is needed to fill this gas. Done. Next we come to, this is a very favorite question of everyone to ask, that all your face mask, if you have ever seen the face mask, all your face masks have certain ports on its sides. What are these ports meant for? Yes, these ports are generally meant for exhalation of the expired gases. This is for what these ports are meant for. So the second thing is that if these ports are meant for exhalation of the gas, then even the atmospheric gas can even enter through these ports. Yes. So someone thought, then let's stop or cover these holes with oxygen. Cover these holes. Now, will that help? The question is big no, because what you're doing is that you are decreasing the exchange that has to take place. That is, if the vents are closed, then where will the CO2 that you have exhaled out will go? And that is something which is going to lead to accumulation of the CO2 in the body rather than helping. Thus, you never put valves or you never put a micropore over these exhalation ports in order to prevent rebreathing. I hope I'm very clear that nothing or no holes have to be closed when you are giving the patient the required amount of oxygen as per the requirements. Moving to one thing about FiO2, the non-rebreathing mask, I have told that the mask fit has to be good. Now, what about the reservoir bag capacity? In infants or in children, it is around 75 to 100 ml, whereas in adults, it is 1.2 to 1.5 liters. Oxygen flow rate, yes, the oxygen flow rate has to be at least 10 to 15 liters per minute. Please remember this. The oxygen flow rate has to be around 10 to 15 liters per minute. High capacity reservoir bag. The patient's inspiratory flow, yes, it is dependent upon the patient's inspiratory flow, because if the patient's inspiratory flow is more, then maybe some amount of air can be entrained inside. Okay, according to patient's inspiratory flow, it is patient dependent. Done. Plus, when we are talking about the NRM along with the reservoir bag which is attached, and a one-way valve is also present. Okay, so when the tubing has been attached to the reservoir bag, and this is the mask, say, what happens is the fresh gas flow is going to come, it is going to get mixed with, it is going to get settled in the reservoir bag. This is the first step that you do when you're putting a reservoir bag. If the question comes that what is the first step, the very first step is you have to stop the valve which is present between the mask and the reservoir bag, such that when the fresh gas flow is open, it is switched on, then the oxygen will start flowing to the reservoir bag and it is not going to leak out. Done. Once the reservoir bag is full, patient is going to inspire through that reservoir bag. But if here the peak inspiratory flow rate are very high, then some amount of air dilution can be seen. Thus, it is a variable performance device. I hope I am clear. Then the patient exhales. On exhalation, most of the exhaled carbon dioxide moves out through the vents, and that valve is present over the reservoir bag, and thus no CO2 is going to enter the reservoir bag. The reservoir bag is going to give 100% FiO2, which may be diluted when it comes over to the mask. I hope I'm very clear. After that, after exhalation, there is one more thing I want to emphasize here. I hope you all remember that extra H. Yeah, that's your expiratory pause. A expiratory pause comes in our breathing pattern, which is around 0.5 seconds. And when this pause comes, there is no exchange which is taking place. This is at this time that pure oxygen is entering the reservoir and filling it and getting the reservoir ready for the next inspiration. So expiratory pause is very important and relevant when we are talking about the oxygen therapy devices, because it is that time when all your capacities, your reservoirs are getting filled with pure oxygen, helping in increasing the FiO2. Great. So I've already told in the one difference between the non-rebreathing mask and partial rebreathing mask is that the FiO2 of partial will be lesser because there is some mixing of the CO2, because that one-way valve between the mask and the reservoir bag is missing. So a non-rebreathing mask can give an FiO2 of 80 to 100% also, whereas in partial rebreathing mask, you have an FiO2 of 40 to 70% only. I hope I'm clear. Next, and one of the most important, is venturing mask. What is venturing mask is? It is a high flow device and it is a fixed performance device. Capacity. The capacity of venturing mask is only that much of the mass that is present over the mouth. That is a low capacity device. And lastly, it is patient independent. It is patient independent because the flow rates that come from this device are very high than the patient's peak inspiratory flow rate. And thus the requirement of the flow rate is met when we use these Venturi masks. See, the principle on which the Venturi masks are based on is Bernoulli's principle, which is a must to know and asked a lot many times in previous year questions. That is, what is the principle on which Venturi mask does work? That is your Bernoulli's principle. Now, what does Bernoulli's principle status? Suppose a liquid is coming at very high velocity. Okay, then a constriction comes. Suddenly we have a constriction that is coming, and all of this liquid has to flow through this constriction, and thus the velocity of the liquid increases very high. And because we have to conserve all the kinetic energy which is now changed and the velocity has increased, so we have a drop in the pressure. We have a pressure drop, and because of that pressure drop, but the patient's requirement of the inspiratory flow rate has to be met, right? This pressure drop leads to what is known as the entrainment of the air. Entrainment of the air in order to fill that void. There is a viscous drag, okay? Because of that increase in velocity, we have a pressure drop. There is a viscous drag that is present, which is going to attract the atmospheric air, and it gets entrained and thus delivered to the patient. But how much air will be entrained from outside is fixed according to the type of the Venturi mask or the type of the baffle that will be used. I repeat, the FiO2 which will be delivered to the patient is fixed, and it is based upon these baffles which are present. As you can see in Venturi mask, we have, this is where this baffle or the Venturi mask is attached. This is the tubing of connection, and this is your mask. This is the tube which is connected to the oxygen port. Done. When we talk about this blue, whenever this blue is attached, we know that 24% of oxygen is being delivered to the patient at a rate of 2 to 4 liters per minute. So it's a fixed performance, high flow, medium capacitance device and patient independent. Rebreathing, no rebreathing takes place because it's such a high flow that all the all the CO2 is being displaced. The other name for Venturi mask is high airflow oxygen enrichment device. That is the other name, high airflow oxygen enrichment device. This is the only mask which is going to give a fixed FiO2 at a very high rate. I hope so Venturi mask is clear. When we talk about the Venturi mask, how much FiO2 will be delivered actually depends upon the entrainment ratio and the oxygen flow. So there is one formula that you all have to learn, because this numerical comes that how much fresh gas flow will be given to the patient in order to maintain such a FiO2 via your Venturi mask. The formula states air entrained, how much air will be entrained, will equal to oxygen from the wall, how much oxygen is coming from the flow meter, upon the desired FiO2, 1 minus the desired FiO2 upon FiO2 minus 0.2. So this is the formula for seeing how much air can be entrained. For example, the oxygen from the flow meter is coming at 10 liters per minute, and FiO2 that we desire, that which baffle we have attached, will give an FiO2 of say 0.6%. Done. So how much air will be entrained is around 10 into 1 minus 0.6 upon FiO2 is 0.6 minus 0.2, which will be around 10 upon zero point 4. Same, that is 10 liters. Air entering from the atmosphere will be around 10 liters per minute. And how much oxygen flow rate we are giving is also 10 liters per minute. So the total flow that is being given to the patient is 20 liters per minute, which is a high flow device. I hope I'm very clear about it, that you should know how much air can be entrained from the venturi mask according to the FiO2. Done. Advantages are that venturi masks are actually very useful in cases of chronic CO2 retention. I repeat, the basic use of venturi mask is in the chronic CO2 retention cases. Coming to yet another very important device to be identified, that is your AMBU bag. The AMBU bag stands for Artificial Manual Breathing Unit or Ambulatory Manual Breathing Unit. Either of the two could be asked. Is it artificial or ambulatory? And both are correct. The FiO2 which AMBU can deliver is around 90%. Talking about the parts of the AMBU, as you can see, this is the self-inflating valve which inflates on its own. These all valves had special ribs in it. They are known as ribs, which provide it with the special ability to self-inflate. Once you have pressed, then it will not keep in this position itself. You release it and it will come back on its own. That is your self-inflating bag. Then you have a patient tent where you keep this mask. You have an expiratory valve and an inspiratory fish mouth valve. There are two valves, one for inspiration. Whenever you press the bag, that valve will open and deliver the oxygen to the patient. Whereas there is one more ports, expiratory ports which are present, on which we have a one-way expiratory valve which opens only when there is desired amount of CO2 to be exhaled, and thus the ports open and CO2 gets exhaled. This is here the expiratory. Then you have a PEEP valve for providing some respiratory assistance. We have pop-off valve. Suppose extra pressure more than 40 centimeter water is developed in your self-inflating bag. So the extra pressure which is delivered can be popped off using your pop-off valve. Then we have a reservoir bag which is attached basically to increase the FiO2 which can be delivered. We have a oxygen inlet tubing which is attached to the fresh gas flow of oxygen. And here also we have a air inlet, one-way valve and oxygen reservoir socket. This is present here. And here again we have a pressure release valve to protect the AMBU from excessive pressures. Okay, this is the AMBU. In the AMBU is divided upon the self-inflating bag capacity. Like in adults, we have around 1.5 liters, whereas in neonates, we use around 500 ml of the capacity self-inflating bag. Sometimes you have seen in your OT that the self-inflating bag is black in color. That was meant for pediatric cases, and this black AMBU bag is also known as the Lardiel's bag. It's also known as the Lardiel's bag. The major disadvantages of this AMBU bag is you cannot use this AMBU bag for spontaneous breathing, because it's very high resistance which is being provided, and patient cannot overlook that resistance, and the breathing spontaneous patient should never be put on AMBU bag. I hope I'm very clear about it. Then we have a air entry nebulizer. These are the images which I'm showing you, and you all should know how to recognize these images. This is a nebulizer for provision of humidified oxygen to the patient. Oxygen hood and oxygen tent. When we talk about oxygen hood, as you can clearly see from the diagram, it is meant for kids less than 1 year. Done. FiO2 which is developed, which was given is around 80 to 90%, and it is humidified. The best part is it is humidified. One thing about humidification I just remembered is that when we were talking about nasal cannula, right, I told you about the flow rates. The flow rates have to be adjusted also, because the major disadvantage of the nasal cannula is that it can lead to drying of your nasal mucosa, bleeding, crusting of the nasal mucosa, because of which you have to limit the amount of flow rate that is flowing through nasal cannula. This is a humidified air, a warm humidified oxygen that is being provided to the baby. And the oxygen flow in the oxygen hood has to be more than 10 liters per minute. Okay, around 15 liters of oxygen is provided through this oxygen hood, and minimum of 10 liters per minute should be given. Okay, in some books it is said that at least 7 liters per minute should be given, but if the option is 710, then yes, you can choose 7, or you can choose 10 liters per minute. Talking about the best part about this oxygen hood is that the child is clearly visible, and the child has no problems. The child won't feel claustrophobic, and child will have no problems when the oxygen is coming through the hood. The child is not going to insert your nasal cannulas, your nasopharyngeal catheters, or your face masks. Next, we'll talk about the oxygen tent. As you can see in the photo, the FiO2 which is delivered by the stent is around 80 to 90%, and again a very high flow of oxygen is needed to maintain the oxygen all around the tent. So we have 10 to 12 liters per minute of oxygen. The things that are asked in oxygen tent is first the air exchanges. The air exchanges are around 20 times the air is exchanged per hour. I repeat, 20 times the air is exchanged per hour. What happens here is, because of a closed tent, you have a rebreathing of carbon dioxide that is taking place, and you have CO2 retention, for which you have this oxygen tent attached to the soda lime. As you can see this too. So we have a pipeline that is going to have soda lime in it, which is going to react with the CO2 so that it could be washed out. But this is a highly exothermic reaction. If you remember from the last class of soda lime, it's a highly exothermic reaction. So in order to cool down the oxygen tent, the oxygen and the air that flows, it is all at a low temperature. I repeat, all this is at a low temperature. Then of course we have soda lime, which is attached to for the expired CO2, and for water vapors which are present, we have calcium chloride. I repeat, for water vapors we have calcium chloride. For CO2, expired CO2, we have soda lime. Coming over to the last part of the oxygen therapy devices, we have NIV mask, non-invasive ventilation mask, which if properly fit can give a FiO2 of 100%. As you can see, this mask, this is the main part of the mask. Here you attach your breathing circuits, and this is your harness or the straps. It is very useful in OSA, obstructive sleep apnea patient, because this mask can provide a continuous positive airway pressure, because of which you don't have that alveolar collapse or the collapse of your pharyngeal space that leads to snoring. Okay, it gives a CPAP. It's a medium dependency, and it can give a FiO2 100%. And what happens in this mask is that this mask can be attached to two devices. One is your CPAP, one is your BiPAP. When I talk about CPAP and BiPAP, as the name suggests, we are going to discuss it very briefly. CPAP means continuous. It is continuous positive airway pressure, maybe during inspiration as well as during expiration. And by BiPAP, and it is same. The inspiratory pressure, the expiratory pressure, both pressures are same. Now talking about BiPAP, as the name suggests, it is bi-level positive airway pressure, in which the pressure of inspiration and expiratory are different from each other. Inspiration is around 15 and expiration could be around 6, or you can have 12.6, you can have 10.5. depending upon the condition. But in bi-level, we have two different kinds of oxygen pressures that are being developed or that are being delivered actually. In inspiration, we have a higher one like 15. In expiration, in order to avoid the basal atelectasis, we have around 6 or 7 centimeter water of pressure. Coming over to the high flow nasal cannulas, which became very famous during the COVID times. Again, these cannulas are less cumbersome than your face mask, because as you can say, in those face masks, the patient can feel claustrophobic. The patient won't be able to eat or talk. So it becomes highly cumbersome for the patient to have that very hard, huge mask over the face. Then came the high flow nasal cannulas. These are nasal cannulas which are inserted into nasal anterior nares. This is the nasal cannula. Then special about is that it has a very high flow rate. The flow rate that can be delivered through HFNC is 60 to 70 liters per minute. Then the oxygen that we get from HFNC is humidified, and it is according to the body temperature. It is the temperature is also maintained. This device has a humidifier inbuilt as well as an air oxygen blender, plus a heated wire breathing circuit is present, which is meant to stabilize the temperature. Done. The maximum flows could be 70 liter per minute. Oxygen is heated to body temperature and humidity is maintained to 99%. Then it is a nasal cannula. The advantage of HFNC is that it, because of such a high flow rate it has, the physiological dead space also decreases, and so do the displacement of excess of CO2 is done via your excess of oxygen. That is, the rebreathing part is very less when we talk about HFNC. It decreases the work of breathing. It will decrease the airway resistance because the flow is coming at a very high speed. And yes, it is very helpful in cases of respiratory failure, and it gives a very good bridge between your oxygen therapy devices and your endotracheal intubation, similar to non-invasive ventilation. Even non-invasive ventilation is a very good bridge between the mechanical ventilation and your oxygen therapy devices. Done? Then it is the disadvantages of HFNCR. It is expensive, it is complex, the ineffective sealing may be there, and yes, you have a false sense of security, because of which you can delay the intubation thinking that the FiO2 of 100% is being delivered by HFNC. Coming over to the last thing, that is the tracheostomy mask or the tracheal collar. It gives an FiO2 of 60 to 80%. Again, it's a low flow, low capacity and variable performance device in which there's nothing but a mask is put over the tracheostomy tube, and the patient is asked to breathe oxygen via this mask. It's a low flow, low capacity, variable performance device. Done. Now, if we summarize the whole of the oxygen delivery devices, see, there could be certain cases, like case scenarios, which can come in the oxygen therapy devices. For example, if the patient is tachypneic and the patient maintains a saturation of around 90 to 95%, so what would be the one of the best oxygen delivery devices? And the patient is conscious. Okay, the one of the best oxygen therapy devices for such a patient. So for such a patient, the answer goes to non-rebreathing mask, in which you can deliver an FiO2 of around 80 to 90% to that patient. So we have non-rebreathing mask as the answer. But if this question comes that a patient is not tachypneic, he has just come over from the general anesthesia and is lying comfortably on the comfortably in the post-operative room. So which oxygen therapy device can be given to this patient? So the advised oxygen therapy device could be your nasal cannula or your Hudson mask, which are quite comfortable and tolerated well by the patient. Now, if the similar kind comes that the patient has to talk or is feeling very claustrophobic, so in that cases, we have your either when you need a low flow, you can use a nasal cannulas. But if high flows are needed and FiO2 has to maintain, then you can go for HFNC also. So these are the case scenarios. The case scenarios are nothing but the relevant information about an oxygen therapy device, and you only have to correlate both of them together. Okay. So let's summarize it. Nasal cannula, I told you it's a low flow device. Minimum 1 to 6 liter per minute. FiO2 max it can deliver is 44%. It is comfortable. It is given via nose and no humidification is done, and there is no reservoir also of this device. Face mask, around 5 to 8 liter per minute can be given. FiO2 maximum could 50 to 60%. Comfort, yes, in middle the comfort is present. Via mouth it is given. Humidification sometimes is present in a face mask because the flow meters that we use sometimes it has water in it, and humidifies oxygen can be provided via the face mask. So similarly, we have the Venturi mask. In Venturi mask, we have a very high flow rate, and the total air. Please remember one thing. When you're talking about the Venturi mask, what is being delivered to the patient is the sum of what is coming via the Venturi mask and how much that Venturi mask, because of that pressure drop or because of that viscous drag, because of that increase in the velocity through that jet orifice, leads to the entrained air. So that is the sum. The fresh gas flow plus the air entrained is the total flow rate that is being delivered to the patient. I hope I've made myself very clear because numericals come out of it. Okay. Then, okay, let's revise the equation once. How much air can be entrained is equal to oxygen that is flowing from the wall, FiO2 minus 1 upon FiO2, sorry, zero point 0.1, FiO2 minus 0.2. This is the amount of air that will be entrained from the valve, from the wall. I hope I've used the correct formula. Let's check it once. Yeah, 1 minus FiO2, sorry. I'm extremely sorry. It was 1 minus FiO2. Okay, and that is the main reason why revisions are required again and again. So the air that is entrained is equal to oxygen flow from the wall upon 1 minus into 1 minus FiO2 that we want to deliver upon FiO2 minus 0.2. Talking about the non-rebreathing, non-rebreathing also, the flow rate is around 10 to 15 liters per minute and FiO2 is around 50 to 90% depending upon whether it is a partial non-rebreather or a complete non-rebreathing mask. Then high flow nasal cannula, it is a high flow device as the name suggests. Around 60 liters per minute of oxygen flow could be there, giving the FiO2 of around 100%. The provision of FiO2 will be around 100% to the patient. That's all for oxygen therapy devices. Thank you and please keep revising.